So let's finish up the video series based on the paper on circulatory shock by DeBacker and Vincent from the New England Journal of Medicine, October 31st, 2013. And there's a few details left to cover. The first is mechanical support. And what this is referring to is mechanical support of the circulatory system. So let's start again with our circuit. And the first thing we'll look at is the intra-aortic balloon counterpulsation pump. So what this means is it's a pump, so it's going to actually, get bigger and smaller as it pumps. Counterpulsation means it goes opposite to the pumping movement of the heart. So in systole, when the heart is actually pumping blood and blood is flowing, the balloon is deflated so that the blood can get past it. Now, in diastole, when the blood is not pumping forward, the balloon inflates. And then this actually pumps blood back upward toward the heart and back to the coronary arteries, perfusing the blood. So, when it's in systole, the balloon is deflated so blood can get past it. When you're in diastole, the balloon actually inflates so that the blood is pumped back towards the heart. Now, I don't know why I went through so much trouble explaining it to you, because a recent randomized controlled trial has shown that this is not very helpful, and so it is currently not recommended. The next type of mechanical support you can get is something called ECMO, or extracorporeal membrane oxygenation, ECMO. And what this really is a heart and lung machine placed outside of the body. And so blood is shunted out of an artery, and it goes to a fake lung that's going to oxygenate it, and then it's going to go to a pump, and then it's going to be returned to the body. And so what this does is it simulates the heart and lungs. And this could be good for a patient who has a reversible heart problem, like maybe they got a very bad myocarditis, or if you're going to wait for heart transplantation. And ECMO can actually be one of two types. It could be veno-arterial, meaning you're plugged into the venous system and the arterial system, or it could be veno-venous, meaning you're plugged both sides into the venous system. So here's our veno-arterial and our veno-venous system. And this has been shown to be helpful in these dire cases, but you're going to have to get some ECMO support, somebody who's very, very, very knowledgeable in this area. There are ECMO technicians and ECMO specialists, usually in the ICU, who can do this. So in summary for this, for mechanical support, balloon pump, not so good. ECMO, good. Next, let's look at the components of oxygen delivery. And you might remember that that's made up of the oxygen content of blood times how fast the blood is flowing, or the cardiac output. So oxygen exists in the blood in two forms: dissolved in the blood, plasma, so in the plasma that's called the PaO2, or it's bound to hemoglobin in red blood cells, and that's the oxygen saturation. So there's a couple of ways this system can fall apart where the oxygen delivery is compromised. If your PaO2 falls down, you're gonna have a state of hypoxia when you're not having a good enough level of PaO2. If you don't have enough hemoglobin to carry oxygen around, then that's a state of anemia. And if the cardiac output is not working right, then you have some sort of cardiac dysfunction. So what you'll want to do then is, in order to maximize oxygen delivery, is you want to decrease hypoxia. So that's why we're intubating our patient and putting them on 100% oxygen to begin with, to increase the PaO2, the oxygen dissolved in plasma. Now, you should know that this plays only a small role, but why not maximize it if we can? Anemia, we want to improve that by giving blood transfusions if the hemoglobin is low, because look, most of the blood is actually carried in these red blood cells bound to hemoglobin. And finally, if the cardiac output, which is the pump that's pushing the blood through the body, is broken, then we need to give some sort of inotropic support, maybe some dobutamine to get the cardiac output moving and the blood pumping so that we can deliver oxygen. So that is oxygen delivery in a nutshell. Now let's visit another topic. So the next concept we'll talk about is about oxygen extraction and mixed venous oxygen saturation. And so here is our heart again, our circulatory system, our lungs, these are our pulmonary arteries, and representing the rest of the body will be Mr. Liver down here. So let's say we measured the oxygen saturation here on the arterial side, and this is after the blood has just come from the lungs and things are going good, and so let's say we have 100% oxygen saturation. So blood is flowing nicely through the system and oxygen is being delivered. Now by the time it gets here to the liver, the liver takes some of that oxygen out for its own use, but it doesn't need all of the oxygen, so some oxygen remains left in the blood. And then that oxygen finds its way going back to the lungs. Now, if you were to measure the oxygen saturation over here, this is the saturation of blood that's already been circulated through the body, and some of the oxygen has been removed. It's going to be somewhere between 60 and 80%. That means that the rest of the body took anywhere from 20 to 40% of the oxygen out. It extracted 20 to 40% out. Now, the blood that has come all the way back around and is going to the lungs, this is called our mixed venous blood, because it's mixed blood from all over the body. And so the saturation here is called our mixed venous oxygen saturation. Or here you can see the S stands for saturation, V stands for venous, and O2, of course, stands for oxygenation. So we know in a normal state, our SvO2 should be somewhere between 60 and 80. Now what happens when we're in a shock state? Well, now we know that the oxygen delivery is impaired. And so all these tissues in the periphery, like the liver here, they're very hungry for oxygen. So when the blood comes by, they're going to scoop out as much oxygen as they can. So the oxygen saturation is not going to be 20 to 40% anymore. It's going to go up. Maybe it's 50%. Maybe it's 60%. Maybe it's 70%. So that goes up. And that, of course, leaves less oxygen in the blood vessels going back to the heart. So there's less going back to the heart, so there's less being delivered here. And so again, now we know that if our oxygen extraction is much higher, we're going to have less leftover oxygen in the mixed venous area. So we'll see this drop. So maybe instead of 60 to 80, maybe it's like 40 to 50%. And so that is one way to measure how hungry the tissues are by measuring the SvO2. The way we used to measure this, though, this SvO2, is we had to get a catheter here into the pulmonary artery. And those pulmonary artery catheters were time-intensive, and they were just not easy to use. And so now we have a surrogate. We don't measure mixed venous oxygen saturation anymore. What we measure instead is the oxygen saturation in this big blood vessel here, the superior vena cava. So now this isn't necessarily mixed blood because it's only including body from the top half of the body. So we don't call it the mixed venous oxygen saturation. Instead, we call it the central venous oxygen saturation because this is the central vein, right? And so it's our marker for oxygen saturation, for the mixed venous oxygen saturation. It's just easier to get here than it is to get over here. And where the normal oxygen saturation of the SvO2 is somewhere between 60 and 80, the normal ScVO2 is greater than 70. They're not exactly the same, but they're close. So we went through that whole explanation just so I could say this one thing. You want to try to keep this number above 70 if you can, and that improves mortality in at least one trial by Manny Rivers. Now, there are 3 other trials that the paper mentioned that are going on right now to test whether this is actually true or not, but for right now, that's what they're mentioning. So finally, in the last few minutes, let's talk about the 4 phases of treatment of shock they mention. And these are listed here. In the salvage phase, you're just trying to save the person's life. So give them the VIP treatment, ventilate them, IV fluids, and any pressors you need to do. In the optimization phase, we want to optimize oxygen delivery, so we talked about those things already, like getting the oxygen up and making sure they're not anemic, and improving cardiac output. And some things that you might want to measure in this case is the mixed venous or the central venous oxygen, as well as the lactate. So check and optimize these numbers. The lactate you'd like to ideally drop 20% in the first 2 hours. In the stabilization phase, you want to provide good organ support. Maybe the kidney took a hit during this, and so you want to make sure you give lots of fluids and make sure the kidney stays perfused, and so the kidney numbers improve. Maybe the heart's not doing so well, and so you need to put them on ECMO until the heart improves. Our goal is to minimize complications from this shock, and so we want these organs to do well. And the final stage is the de-escalation stage, where you're going to wean off all the things that we did. So you're going to wean them off the intubation that you had done here. You're going to wean them off the pressors. You're going to hopefully wean them off any excess fluid that we've given, and you might have to take some fluid off at this point. And then hopefully, from there they go on to living a happy life. So these are the 4 stages in treatment, and in the emergency department we're probably going to be doing these 2 stages, salvage and optimization. So in this last video we covered a bunch of stuff. We covered the mechanical support. We said balloon pumps don't help, but ECMO does. We looked at oxygen delivery, and we know we want to prevent hypoxia, anemia, and cardiac dysfunction. We even looked at ways of measuring how well we're doing with our central venous oxygen saturation here, and we talked about oxygen extraction, and finally the 4 phases in treatment. So if you're interested, I recommend that you find this paper and read it. Now perhaps with this knowledge it'll be a little bit easier for you to understand, but there's a lot more in here that I didn't cover, and it's a pretty good paper. Alright, I'll talk to you later then. Adios. Bye.